Amaurotic familial idiocy, an outdated term for Tay-Sachs disease TSD, which is concisely defined by OMIM online Mendelian Inheritance in man as an autosomal recessive, progressive neurodegenerative disorder, which in the classic infantile form, is usually fatal by age 2 or 3 years, results from deficiency of the enzyme hexosaminidase-A. Autosomal points to the gene for TSD residing on the nonsex autosomal chromosome, namely, chromosome 15q23q24. Recessive indicates a person with 2 copies of the gene has TSD, whereas someone with 1 copy is a carrier in normal health. TSD worsens with time, as the central nervous system progressively deteriorates. The classic textbook type of TSD has its insidious onset in infancy. The child with TSD usually develops normally for the first few months of life. An exaggerated startle reaction may first be noted. Head control is lost by 6 to 8 months of age. The infant cannot roll over or sit up. Spasticity and rigidity develop. Excessive drooling and convulsions become evident. Blindness and head enlargement set in by the 2nd year. Fatal by age 2 or 3 years today would be modified to fatal by age 5. After age 2, total constant nursing care is needed. Death is usually to cachexia, wasting away, or aspiration pneumonia initiated by food going down the wrong way into the lungs. TSD is due to deficiency of an enzyme, the protein needed to catalyze the specific chemical reaction within the body. Lack of the enzyme, which results in failure to process the lipid, the fat which accumulates and is deposited in the brain and other tissues, to their detriment. The enzyme is called hexosaminidase-A, hex-A, and the lipid that is deposited is called GM2-ganglioside TSD is a model of a fatal metabolic disease that occurs primarily within a well-defined subpopulation. It is one of several genetic diseases found more often in persons of Jewish origin. Other Jewish genetic diseases include Gaucher disease, Niemann-Pick disease, Bloom syndrome, and factor XI deficiency. The frequency of TSD is much higher in Ashkenazi Jews of European origin than in other groups of Jews. In the U.S., 95% of Jews are Ashkenazi and are at risk for TSD. TSD occurs more rarely in non-Jews. Knowledge of the biochemical basis TSD has permitted screening programs for carrier detection and prenatal diagnosis of TSD. There are forms of TSD with somewhat more hex-A and hence later onset, termed juvenile TSD and adult TSH. Alternative names for TSD